Fentanyl is a synthetic opioid. It's much more potent than morphine and hence given in microgram quantities rather than milligram quantities. So, I mean, a rough conversion is, I suppose, that using off the top of your head is probably, 100 to 1. So 100 mics of fentanyl is equivalent to about 10 milligrams of morphine, although it's probably a little bit more than that. Once again, when you're on the trot and you're trying to calculate doses, often you like to just be able to do it in your head if you can. So it's a lot more lipophilic than morphine. It's a highly selective mu agonist, and hence you wouldn't expect to get problems with itch with fentanyl. So once again, it might be a reasonable alternative for someone who has itch, but as I said, itch is very unusual. Less effect on the GI tract than morphine, and so hopefully there's less problems with constipation. After IV injection, it's cleared in 2 phases, probably because of its lipophilicity. So there's a rapid redistribution, and then there's hepatic metabolism and renal clearance of the drug. With the patches that we're most familiar with, it's a constant delivery rate, which corresponds to the surface area of the patch. So little patches give little dose, and big patches give a big dose, and lots of big patches give a very big dose. So the thing about it is that it's slow onset, slow offset. So because it sets up a reservoir in the subcutaneous tissue. So the different doses, so the 12.5, or what's called the 12, is the most recent addition to the patches. And once again, I use a conversion in my head. So 100 micrograms per hour is roughly equivalent to 100 milligrams of subcut morphine per 24 hours. So that's about 200 milligrams of oral morphine per day. But I'd suggest that you probably refer to a conversion when you're looking at. But if you think when Duragesic first came on the market, the conversion for the 25 microgram patch to morphine was 0 to 134 milligrams of oral morphine per day. That's a pretty good big range, isn't it? So once again, conversion tables, not an exact science. Usually they're changed every 72 hours, but you do find some patients who don't get that 3rd day relief, and initially we used to change them every 2.5 days, but my suggestion from a practical level is just change them every 48 hours. So if you find a patient who, in the last 12 hours or so, they're starting to get pain back, just make it a 2-day patch rather than a 3-day patch. It's much easier to do it that way. So the patch that we have now is the Patch Mark II. So it's another type of patch. It's this new matrix patch. So for those of you who can remember back, the patches were different and thicker in the past. And the other thing is, just if you keep putting the patches on, one of the problems that you get with the patches is sometimes skin irritation. So if you keep using the same area of skin, I would imagine that would become an issue. So you put it on, you can rotate the site. So some patient will just put it on different arms and just keep rotating it back, so you don't put it on the same side. So should not be used in acute and unstable pain. There have been articles written about using it in unstable pain, but we don't do it. So if you've got unstable pain where patients are needing lots of breakthroughs, then use something differently. Use a subcutaneous preparation or an oral short-acting preparation. So if the patient can't tolerate the naturally occurring opioids or semi-synthetic opioids, you can use fentanyl in a syringe driver. But the problem is the concentration. So you don't get a lot of bang for your buck by putting fentanyl in a syringe driver, because 100 mics in 2 mils. So you're probably going to be using many mils if they're needing high doses. So we don't tend to use fentanyl in drivers very often, but we do use it. Because you think that a 100 microgram patch is going to provide the same as giving 2 mils of the drug 24 hours. So that's 48 mils of parenteral will be provided by a single 100 microgram per hour patch. It was initially approved for cancer pain only in this country, but is now used for chronic non-malignant pain as well. Advantages over morphine. So it's said the constipation is less, and there's been a couple of trials comparing transdermal fentanyl and sustained release morphine, and that seems to be a real issue. Less daytime drowsiness with the drug, And the overall preference has been in those head-to-head comparisons. Once again, you wonder who funded those trials, but there is no significant difference in nausea and vomiting. And that's interesting because the impression I get is that fentanyl probably is better. If someone has issues with nausea and vomiting, then I'd certainly think about using a patch. Once again, that's just a decision about opioid rotation more than anything else. Advantages over morphine. So it's said that constipation is less, and there's been a couple of trials comparing transdermal fentanyl and sustained release morphine. That seems to be a real issue. Less daytime drowsiness with the drug, and the overall preference has been in those head-to-head comparisons. Once again, you wonder who funded those trials. But there is no significant difference in nausea and vomiting. And that's interesting because the impression I get is that fentanyl probably is better. If someone has issues with nausea and vomiting, then I'd certainly think about using a patch. Once again, that's just a decision about opioid rotation more than anything else. So the oral transmucosal fentanyl, so they're the Actic lozenges. Has anyone prescribed those at all? Very much a niche type drug. I can't remember the last time I prescribed it because you prescribe it with their starter packs that you can prescribe through the PBS. So it gives you a choice of different strength lollipops or hardened lozenge on a stick, as you should call it. So they work very quickly. So peak plasma concentrations in 20 minutes. And that's about how long it takes to suck the lozenge, really. So bioavailability is about 25%. So 25% of that is direct, and the other 75% goes through the GI tract. So the absorption is not very good. It's what you get transmucosally that's important. And it's the only drug that's really been developed specifically for breakthrough or incident pain. And there's various dosages, and as I said, there's a starter pack. But we've never used it in the unit, ever. Never, ever used it. If there was someone at home and perhaps they were having dressings that were quite uncomfortable and they didn't want to have injections and they were cognitively okay, then it may be quite, a useful alternative rather than, giving them oral whatever. Because oral whatever takes probably twice as long to get to peak effect. And I remember when we've had speakers at conferences from overseas who were involved in the original sort of research with these drugs. They did give it fairly good reports. It is a useful thing to have, but for inpatients, when we just use parenteral stuff. They have developed a sublingual tablet overseas, so something you just put under the tongue. It's thought that it might be more, rather than sucking on a lozenge that you've got to spin around your mouth, just to have a sublingual preparation. But we don't have that in Australia at present. Methadone has been around for a long time. It's lipophilic. It's well absorbed and bioavailability is very good. The issue is that it does have a long half-life, and sometimes the half-life of the drug exceeds 100 hours. Well, one of the good things about the drug is that for patients who've got renal impairment and liver impairment, then it doesn't significantly affect methadone clearance. So it's good in that respect. Whereas morphine, you would be very, very careful about someone who had significant renal impairment, maybe not quite as worried about someone who had significant liver impairment. Metabolized chiefly in the liver, half the drug and its metabolites are excreted by the intestines and half in the kidneys. In a single dose, so this is a single dose, remember, that's about half as potent orally as via the parenteral route. It's marginally more potent than morphine in single IM studies, but several times more potent given the repeated doses.